Okay, not too distant future, but anyway, thanks very much. Thanks very much, everybody, for coming to this month's pain rounds. And we're really looking forward to this. Those of you who are, whether you're in the room and you want to collect your continuing education credits, or if you're signed on online, I believe that the item labeled ETA code at the bottom, the ETA CVGL, is the code that you need to remember in order to sign on later, complete an evaluation, and receive your formal continuing education accreditation, or your little note that says you really were in school and you weren't fooling around reading or playing football or something. So keep track of those codes. We're very pleased, actually, a brief piece of history for anybody that's listening online or even here. We have in Hamilton had interdisciplinary pain treatment programs since the early 1980s that I am personally aware of, because I did an elective with a neurosurgeon when I was a medical student who consulted to the multidisciplinary program on a regular basis. And the program then contained psychologists, psychiatrists, rehab therapists, physical therapists, occupational therapists. I don't think there was such a big emphasis on pharmacists at the time. I can't remember if there was one involved or not. So was there one involved? And social workers, and as well as a cadre of medical and surgical consultants that were used. And the group, in its most sort of successful manifestation, it gradually disappeared over about, well, certainly by 1990, there was no formal interdisciplinary program supported within the OHIP realm at all, particularly in Hamilton, but it survived as a third-party program, and so it was able to keep a core of people together over a number of years, some of whom are still engaged in the program, some of whom have moved on, but it provided a core that continued to create a functioning interdisciplinary treatment program. So that several years ago, when the Ministry of Health in Ontario decided that it was important to fund interdisciplinary healthcare, Hamilton was very well positioned because we had a cadre of people who were already doing that. We were able to blend the third-party supported program, the CPMU, the Chronic Pain Management Unit that was based physically up at the Shadok site. We were able to blend that with the OHIP largely parallel practice physician-led program that was based then at the General Hospital site, bring the two of them together in the newly built facility here at MAC. And then when the Ministry of Health decided to fund the non-physician elements, we were able to effectively double the size of the interdisciplinary treatment program very quickly. We'd probably the fastest one in the province to turn on because we already had the people, and we just needed to continue to add other people to the mix. So that was really excellent because it meant that we were able to really get two of everybody that we used to have one of and support them on a consistent basis, have a predictable budget, and allow us to proceed that way. Among other people, that allowed us to bring on Dr. Laura Katz. So Dr. Katz is presently certified as a clinical psychologist, but PhD psychologist originally from Queen's. We've forgiven her for that because there are actually good people at Queen's. She left to sociology development, stunning insight, and came to join us. But throughout her work, she was really interested in the process of coping with chronic illness, and became particularly interested in chronic pelvic pain in women. She's joined the group here and has been functioning as a clinical psychologist for the last 2 years, and was integral to creating the new multidisciplinary program for chronic pelvic pain in women. And so Dr. Katz is going to bring that to us now. Thank you. Thanks very much, Laura.
Thank you so much for the kind introduction. everyone for joining me in this room and for those on today. I'm going to talk to you about the development of our interdisciplinary chronic pelvic pain program. So I'll talk quite a bit about what the program is and then go through some preliminary results as well. So there's three main objectives that I'd like to go through today. The first is to talk about the prevalence and the impact of chronic pelvic pain. The second is to introduce our novel program. And the third is to present some updates on the progress of our program and some preliminary results. So we know that chronic pain in Canada, about 1 in 5 Canadians suffer from chronic pain. And it's associated with a worse quality of life as compared to other chronic diseases such as chronic lung or chronic heart disease. We also know that individuals with chronic pain have about double the risk of suicide, and we see quite a bit of that suicidal ideation in our clinic as well. The cost of chronic pain in Canada is estimated to be about $56 to $60 billion a year, which is outstanding. And given that, it's unfortunate that pain research and management within our healthcare continues to be grossly underfunded and underserviced. And this is even more concerning when we think about chronic pelvic pain, which we're going to start talking about, because that in itself is grossly underdiagnosed, and that makes it underfunded and underserviced as well. So what is chronic pelvic pain? So chronic pelvic pain really is this umbrella term on how we understand a whole bunch of different conditions, and it's defined by the Royal College of Obstetrics and Gynecologists as intermittent or constant pain in the lower abdomen or pelvis that happens for at least 6 months' time, that's not occurring exclusively due with menstruation or intercourse, and it's not associated with pregnancy. There's pain in the areas such as the pelvis, the interior abdominal wall, and the lower back or buttocks. And it's serious enough to cause medical disability or disability as well. Often when we think of that umbrella term, there's other terms that come along with it, so things like endometriosis, pelvic effusions, chronic pelvic infections, things like fibroids and vulvodynia, interstitial cystitis or bladder pain syndrome. We also have some of the GI conditions like inflammatory bowel disorder or irritable bowel syndrome, chronic UTIs, and bladder syndrome. So this is something we don't talk a whole lot about, but we know that the prevalence for women in reproductive ages is anywhere from 14 to 24%. And what's outstanding is the fact that 14% of all women are said to experience chronic pelvic pain at least once in their lifetime. So this is a significant issue for all of us. So what exactly is the pelvic floor? I feel like we talk a lot about this day to day, but I'd like to go through a little bit about what it actually is. So we know that pelvic floor dysfunction is a major contributor to a whole multitude of dysfunctions, including pelvic pain, issues with urinary and bowel functioning, and sexual dysfunction as well. So what the pelvic floor actually refers to is all of the structures that support that entire pelvic cavity. And for healthy functioning, we know it controls bowel and bladder continence, sexual functioning, and core stability. And it also controls the ability to shorten the muscles up, creating a lift for the pelvic floor, and then relaxing the muscles down, allowing them to step back in their place. So actual dysfunction in the pelvic floor can occur both in the muscles, either increased or decreased tone, the fascia, so either uterine or bladder prolapse, or even the viscera, so things like the urethral or rectal spasms. And we know that when hypertonicity is present, the resting position of the perineal body is further upwards in the pelvis and unable to return those muscles down to normal position. So thank you for bearing through some of the anatomy of the pelvic floor. Normally we have our fabulous Adria Franson, who does a lot of this kind of instructions in psychoeducation. She's sitting right here, so if you have any questions, you can have her as well. What we do is when we introduce our program, we do a lot of psychoeducation to patients to help them understand what their pelvic floor is and how it helps them in their body function. And we do a really neat exercise with them to help them understand that that pelvic floor is kind of like it's a sling or a band or a basket. So we have about 4 or 5 women stand in a row, one being the pubic bone, one being the urethra, one being the pelvic floor muscles and the anus, and so on. And we have them hold these rubber bands. So we can show them that when their muscles are tight, the bands pull and all of the structures start to bend into each other. And that creates these pelvic floor dysfunctions. Alternatively, when the muscles are too loose and they can't tighten up and strengthen, things can fall through and again bump into each other. So this is a really nice way to show patients and help them understand the three-dimensionality of the pelvic floor and why certain things of our program and different components of it can be so helpful for them. So pelvic floor dysfunction, there's a variety of different reasons for it, some being faulty mechanics, either postural or structural dysfunction, injury to the pelvic floor muscles, such as in childbirth or surgery, and also inflammatory pain disorders like IBS, endometriosis, and IC. So in terms of a lot of the referrals that we've been getting into the clinic, the majority of them are falling into this inflammatory pain condition, and then that's a lot of what we can help with. So when a woman has pelvic floor dysfunction, it really alters their pain response because that muscle activity stays upwards and starts to push into structures. And why this is difficult is because a lot of the times and historically, treatment has focused on telling women to do some strengthening exercises like Kegels to tone everything up. And now what we're trying to understand about the pelvic floor is that if those muscles are already too tight and lifting everything up, doing further exercises to push those muscles together is probably going to do more harm than good. So now a lot of the pelvic floor dysfunction treatment focuses on and involves stretching and lengthening those muscles down to help downregulate the nervous system and decrease that pelvic floor tone. So it's not surprising that chronic pelvic pain has a significant impact on both the women, their families, their lives, their roles in society and healthcare. It's a chronic and debilitating condition, and what makes it quite difficult for treatment is the etiology is very often multifactorial. So medical treatment becomes really difficult because if we don't know where something's coming from, how do we treat it? A lot of the times women will have years and years without getting diagnoses, and they rely on symptom management. So women will report things like they have a lot of absences from work, they decrease fertility, personal losses such as the decreased ability to function in roles such as at home. They have increased medication consumption and gynecology surgeries. And like I mentioned before, it's really a significant cost to our system because of the high healthcare utilization. When we look at how women with chronic pelvic pain compare to other healthy and age-matched controls, we know that it's associated with poor outcomes like increased pain, worsened quality of life, sleep dysfunction, depression, pain catastrophizing, anxiety, stress, and issues with sexual and social functioning. There's also a higher prevalence of early childhood sexual trauma that's commonly reported in women with chronic pelvic pain, even more so than individuals with general chronic pain as well. And I think what I find the most startling when you start to look in the literature in women with chronic pelvic pain is many of these women have experienced symptoms for years and years without actually getting a proper diagnosis, assessment, or treatment. So on average, it's said to be about 6 years, but some studies even support as high as 11 years. So that's a long, significant decade of a woman's life where they're not being able to get the help and support that they need. So this is exactly what my graduate research focused on. So I'll just spend a couple minutes talking about how the literature helped to shape up the program that we have today. So my master's research looked at how we can understand how pain turns into disability in women with interstitial cystitis. So if you look on the graph here, This is pain and this is disability. And what we see is that this relationship is really explained by pain catastrophizing, and a little bit by negative affect, which is depression and anxiety, and not so much so with social support. So we know that pain catastrophizing is an incredibly important construct in helping people to start to cope with their pain and decrease their disability. And on this next slide, this was the basis of my PhD research, and it's a similar model, but very much so blown up. And what we see is that when we go from pain to disability, so from left to right, we know that things like negative beliefs about how people feel about their illness can lead to illness-focused coping, so things like guarding and resting, which leads to physical disability. We also know that when an individual has the ability to believe they can control their condition and cope with it, that leads them to actually engage in wellness-focused coping, such as pacing and breathing and relaxation, and that leads to better mental health and well-being. The most surprising thing about this model here is this factor here, emotion regulation. And why that's important is because it's impacting both physical disability and mental health. So what this shows is that if we can teach women how to regulate their emotions and their stress, that's really going to help both their physical selves and their mental well-being. And so a lot of the basis of this work was what helped, Adria and I come together to develop this program that I'm going to be presenting today. So before we started figuring out what we wanted our program to be, we did a little bit of research to see what other kinds of programs exist in Canada. And this was about a year and a half ago that we started our investigation. And we saw relatively few programs exist at all. The programs that do exist are primarily biomedical, focusing on medical intervention, physicians, and medication. And there were a couple that were multidisciplinary that had other disciplines involved. However, a lot of their integration was quite siloed. So they would see a physician, and then they'd go on to see a physiotherapist, and there wouldn't necessarily be any crosstalk between them. So we wanted to offer a program that was truly interdisciplinary in nature because we know this to be the gold standard of treatment. So thank you, Dr. Buckley, for bringing up the program that we have going on at the clinic, and that's exactly what we wanted to do. I was fortunate and lucky enough to come to work for a great clinic that has an ongoing program. So we wanted to not reinvent the wheel, but build on the basis of knowledge that's been going on in this clinic for some time. So we adapted the components of our already established ongoing program based on the evidence in the literature to be able to be specific for the needs of women suffering from chronic pelvic pain. So we have a number of disciplines involved in our clinic. For our particular programs, they're all female. We have a female pharmacist, occupational therapist, social worker, physiotherapist who specializes in pelvic floor, nurse practitioner, a psychologist, and physicians as well. This program is primarily based on women with chronic pelvic pain, but we've been getting a lot of male referrals as well. So we hope in the future to be able to develop a similar kind of program and support males. So to tell you a little bit about the flow of how patients are coming into our clinic, we are requesting that the referrals come from either OBGYNs or urologists in the community, or by one of our pain physicians at the MDG clinic. And after we receive an initial referral, we'll invite them to one of our orientations. So this happens on average between 6 to 8 times per year. And it really is an education session for the patient to learn about pelvic pain, learn about their pelvic floor, and to decide if this kind of program that's quite active, engaged, is going to be beneficial for them and their well-being. If they decide that that's something that they want to come to, we invite them for an interdisciplinary assessment, and that's both with physiotherapy and myself psychology. So in the physiotherapy assessment, there's a general assessment to see how their bodies are moving, and there's also the option for an internal pelvic exam. And the reason for that is so Adria can determine if their muscles are either hypotensive, so too tight, or hypotensive, and you can strengthen it. In the psychology section, I do a brief psychological screener just to look at how people's moods and anxiety is functioning and how generally they're coping with their functions. We also administer psychometric assessments at outcomes so we can see their baseline results. If we deem them to be acceptable and they're interested in coming to the program, we invite them to our 8-week interdisciplinary program. So just a little bit about some inclusion and exclusion because it's a new program, so we'll be getting a whole variety of referrals. So we're looking for women who have had pelvic pain for at least 6 months. So if somebody had recently gotten a UTI and they've had pelvic pain for 2 weeks, probably not a good referral. The majority of people that we've been seeing have had pelvic pain for years and years and years, 5 to 10 on average. We want a referral from an appropriate source, so someone like an OB/GYN or urologist or one of our pain physicians. And the reason that we're looking for this is because we want to make sure that the patients coming in have had the opportunity for appropriate diagnostic assessment before we're teaching them skills and strategies to palliate their symptoms. So the last thing we want to do is have a woman come in and not have the full opportunity for all of the different kinds of treatments that might be beneficial to them. So it's an adult program for 18 plus years of age, and they need to be able to read and write in English. Some of the exclusion criteria for psychological symptoms, if they're actively psychotic or they're really in severe psychiatric distress. And this is because we want them to be able to engage and benefit from the program, and if they're so emotionally dysregulated or not able to engage in the program, it's probably not a good fit for them at the present time. So we send a referral back, asking them to potentially do some mental health work, and then have a re-referral back in. In terms of physiotherapy, some of the exclusions are if they're a falls risk, if they're not able to participate in a group physiotherapy program, and if they're dependent, need help with their self-care and transfers. We really want to tell patients that they need to be aware that their pain is not going to be taken away. If patients come in and think this program is going to fix them, then that's not the place for them. We want them to also be interested in making life changes in order to learn new skills and strategies to better manage their pain and improve their life. So as part of our program, they're going to learn strategies and skills in the group sessions that can help them manage their pain more effectively. We know that it's going to help them be less disabled and have less interference by their pain problems, less emotional stress and helplessness in terms of their pain and pain experience. They're going to learn better coping strategies, especially when in flare-ups, and we're hoping to help them increase their productive activity in meaningful and valuable areas of their life. So in terms of the initial assessment, it's to assess for group participation and suitability. Like I mentioned before, it's both a physiotherapy and a psychological assessment, and it's both for the daily functioning of their physical movement, and then there is this option for the internal pelvic exam. By all means, if the patient is not comfortable with that, that's completely okay. So far to date, everybody that we've assessed, nobody has declined the assessment, and they were very much interested in it because it's an opportunity for one session of free pelvic floor assessment, which is quite costly if you try to get it in community. There's also the mental health assessment and the administration of the baseline questionnaire. So if there's somebody that's interested and eligible, the program happens once a week for 8 weeks. We're running it on Tuesday afternoons from 1 to 4 p.m., and there's about 6 to 8 individuals per group. And each day they come in, they have a psychoeducation class, they have an activation fitness class, and that's learning ways to exercise and live with pain, and also really down-regulate the nervous system that those alarm bells that keep ringing. And these will include specific pelvic floor exercises for down-regulation techniques. We also have mindfulness every day to come in for about 30 minutes, and this is to introduce them to the theory of mindfulness in the practice, and also, again, to learn various skills and strategies to help with regulation of their nervous system and unwinding and change the relationship with their body and pain. We also have 30 minutes of goal setting. That way people prescribe goals for themselves every week, and they're able to have the group accountability to help them make some progress in terms of their goals. So there's 8 weeks, and we have 8 psychoeducation classes, and briefly I'm going to run through what each of them are. So the signs of chronic pelvic pain is by physiotherapy, and it's discussed why, in fact, women do have that, the purpose of it and how it works in the body. Adria talks a lot about the nervous system and those alarm systems that keep ringing and how we can start to bring them down and wind them down. We also have a class on sleep, and this is facilitated by a pharmacist. It follows a similar model to a cognitive behavioral therapy for insomnia on one session, which we know to be effective. And essentially, it's to learn about insomnia and how it impacts pain and overall health, and to understand how sleep practices can actually lead to better quality of sleep and more consistent sleep. One of the really important classes is dealing with flare-ups, and that's by physiotherapy as well. And it's to understand how flare-ups are related to your nervous system, and to start to look at all the different skills and strategies and techniques that you can use to better help you cope with things, and also to gain that self-efficacy and that confidence in coping when you do have to deal with it. There's a class on emotion regulation that's facilitated by psychology. The main goal is to really understand the theory of emotion, so why we have emotions, why they work for us, and how that relates to the nervous system. So to understand the connection between structures, thoughts, feelings, bodily sensations, behaviors, and really how that affects your experience of pain and your pain management. And then also to learn some strategies on how to better manage your emotions and let go of that emotional suffering. And that's true for both depression, anxiety, and chronic pain. If we can teach patients to better let go of that emotional suffering, you can really change that relationship that you have with your body. There's also a psychoeducation class on trauma and chronic pain, and that's facilitated by psychology as well. And this is to learn the basis of symptoms of trauma, post-traumatic stress, and the connection between chronic pain and trauma. And this in itself, a lot of these classes, you can have 8 weeks altogether, so we just kind of scratch the surface. But we try to leave patients with a little bit of skills and strategies to develop more balanced and realistic thinking about their pain, stress, and how that connects to some of their traumatic experiences. There's a class on communication and sexual intimacy, and that's by social work and psychology. And this is essentially to learn how pain can impact your communication and your relationships. We talk a lot about the sexual response cycle, both the linear and the circular sexual response cycle, and this leads into how women can start to develop skills and strategies for effective and assertive communication, especially within the context of intimacy and their intimate relationships. We have a class on activity education and pacing, and this is facilitated by OT. Essentially to learn about the implications of pacing and energy saving strategies so they can gradually start to do activities without flaring themselves up. Also, the OT can help them identify common barriers to managing day-to-day tasks like household chores and activities, and learn basic principles on how to engage in day-to-day activity when living with pain. Our final class is on the anti-inflammatory diet for bowel and bladder management, and this is facilitated by either a dietitian or a nurse practitioner. And essentially, it's to understand the role of 3 main macronutrients and the role in body functioning. Also to understand how vitamins and minerals play a role in pain management, especially in terms of that pro-inflammatory and anti-inflammatory diet, and how that can help women both heal their bodies and engage in pain management. So, as you can imagine, this is a pretty active and engaged program, and it's definitely not for all patients at all stages of their life. So we always want to let them know that if this group program is not for you, they still have the option of seeing a physician in the clinic, and they can also participate in the general interdisciplinary pain program, which is a little bit less intensive. Also, if now is not the right time, they can always come back to the program at a later time when it can come back. So here's the exciting part that I get to talk about, some referrals and how the program is going. So I think we opened up our referrals in winter 2018, so just about this year. And so far we've had about 94 referrals to date. 40 women have attended an orientation session. A lot of times the women will bring their partner, their families, their friends, because it's a really great educational opportunity for them to have their people in their lives understand their experience and what they're going through. From there, scheduled to attend in the upcoming session and assessment. And 21 have had scheduled and completed assessment so far. So our first iteration of the program was in spring 2018, and we completed it with 8 out of 9 participants completing the whole program. And I just wanted to present you a little bit of data on what we have. I always have to present this as a proviso because our N is 9. So hopefully shortly we'll have an N of much greater, but this is the data we have today. So the average age of women is about 33, and most have been off work for about 3 years. And like I mentioned before, most of these women have had pain for about a decade, so that's a long time. About half are married or common law. Maybe about 20% are employed, with about 67% receiving supplemental income. All of our participants were Caucasian and quite educated as well. In terms of the other kinds of diagnoses that women came in, the majority of the women had endometriosis. Many of the women had fibromyalgia, IBS. About almost 90% reported anxiety and panic attacks, and 90% depression. 67% reported urine loss. About 89% reported pain with bowel movements, and about 56% reported pain with sex or insertion of objects such as a tampon. So I included this because I find it quite interesting. So here are these women who are about 30 years old, have been off work for about 3 years, have had pain for about 10 years. So what kind of treatments have they actually tried? About 78% have tried acupuncture, as well as antidepressant medication. Many of the women have tried contraceptives, as well as seeing a gastroenterologist. Herbal medicines, also common, as well as massage and narcotics. Majority of women have had at least 1 surgery as well. About 30% have had nerve blocks. And these last 2 I included because these are kind of the big parts of our program, and we see after 10 years, very few of the women have ever had any pelvic floor physiotherapy, and 0 of the women reported any psychological support. So this is maybe my favorite slide to show, some very preliminary results on improvements in our program. So after the 8-week group, the women demonstrated improvements on all of the outcome measures we showed. So I know this is a small N and we don't have a control group, and we're working towards that, but it's nice to be able to show some data on improvements in a hospital program. So there were improvements in central sensitization, so how much their nervous system was aroused, how much their pelvic pain impacted them on their quality of life, their pain catastrophizing decreased, depression, anxiety, and stress decreased, their fear of movement, so their kinesiophobia decreased, and their self-efficacy really improved. So we like these results, and we're excited to be able to increase our N to show more of this. So just some follow-up updates. We're continuing to assess for our fall program. Our fall program is actually started running in October, and it's ending December 11th. We recently had an orientation today, and we're currently assessing for patients for the winter program. That's going to run from January to March. And if you're interested in sending a referral in, our next orientation is going to be December 3rd. So I think that's about it. I'm really excited to stand here today and share some of those preliminary results. It's been quite a journey in getting this program up and running, and we're really excited to see where it goes and all the referrals to come. So thank you so much, and I'll open it up to some questions.
Questions?
Yes.
Yeah, so Laura, you found that only 2 of the 9 women in your first group attended pelvic floor physiotherapy. Now my question is, how new is pelvic floor physiotherapy in our world of physiotherapy? Because I must admit, I've been in the system for a while. This year was probably, or maybe last year, when you guys started working with patients. For me personally, it was the first time that I heard the term pelvic floor physiotherapy. So if you could,
So I can start with that, and then I'll. Sure. Of course. So I'm going to repeat the question. Dr. Happy-Do, thank you for your question. Just on the fact that how new is pelvic floor physiotherapy in our world and pain management and so on? And it just seems as if in the past year or so it's been kind of everywhere. And so I'm going to answer a little bit of that, and then I can pass it back to you, Adria, if that's okay, and if not, pass it back to me. So I wonder if it's a recency effect, because Adria and I have also been talking a lot about it, and there's been a lot of women in the clinic and so on. But also, the literature has kind of exploded with it as well. And other colleagues in other pain management programs across Ontario, there's been this interest and this need to open up these pelvic pain programs kind of across the board. So I'm really happy that we're kind of at the forefront and pushing our program forward, but it definitely is something that there's interest quite a bit of.
I don't exactly know when it started, but I know over the last 10 years it has been growing. I think it's been helping along the way with the more and more research linking pelvic floor dysfunction to low back pain. And prior to that, I think many people thought it was related just to female problems. And I'm unfortunate to say this, but sometimes that doesn't really help the cause of getting knowledge out there. But as we move forward, there's more research coming out showing that there's a link to our back. And now there's a link to our back, we're understanding, this is affecting more than just females. And I think that's been helping us bring it to the forefront. More and more physiotherapists are getting introduced in their undergrad programming now than they ever had in the last 2 years. Like Matthew was starting to talk about it. And I would say courses available for entry level doing this work has exploded over the last 1 or 2 years. So it is relatively still new, and I think it will continue to grow as men start to come to the forefront and get into it as well.
Do you want me to try to summarize some of that? Or?
Quick summary.
Okay. So thank you, Adria. So I think the gist of what you were saying is that I think it's starting to be around over the past 10 years or so, and especially over the last 2 years when it's becoming more and more into training, especially in physiotherapy training as well, and especially since research has started to link pelvic floor to low back pain, which we know to be indicated, and this is becoming less of a female issue and more of a male and female issue, because both men and women have pelvic floors and experience low back pain. So as this starts to become more general and more people are getting knowledge of it, it's kind of exploding in the world of healthcare as well. Sound okay? Anything else missed out? No. Yes?
So from physician's point of view, is this a diagnosis exclusion, or is it something that you can diagnose before it past 10 years? Like they go to gynecologists, urologists, they did all these things, rule out interstitial, this, and then 10 years. Is there any way that you could diagnose clinically?
Yeah. Before the 10 years. And so that's what I'm really hoping for. We've given a couple of community talks and so on, is to really increase the public awareness of pelvic pain, because let's say some of these diagnoses like endometriosis or interstitial cystitis were diagnosed in year 1 of 2 instead of year 10. think of the decreased impact on the individual in their world, on healthcare utilization, on the system, on medications and gynecology, and all of that. So I think it's a lot about awareness that this is an issue that there is, in fact, treatment for. And hopefully women can start to have assessment, diagnosis, and treatment sooner than that 10-year mark. Does that make sense? I know some of the diagnoses are exclusionary. So, for example, the diagnosis of IC, sometimes you can do a cystoscopy and find some Hunter's ulcers, but most of the time it's diagnosing, it's an exclusionary diagnosis, and if nothing else comes up, they can often make a diagnosis of IC. So I guess it depends in that way. Sonia?
So women who want pelvic for exercise in the community, that the pertaining for it?
Correct. Correct.
And then the other is your topical setting, the other Ministry of Health clinics that are funded by health. You're talking about pelvic pain programs and other types.
Yes. So if you would like to have pelvic floor physiotherapy in the community, it is out of pocket and for a fee. As far as I know, I don't think there is anybody in OHIP in the ministry right now who's doing full individual pelvic floor physiotherapy. I have been in contact with a number of people from other programs, the Kingston program. I know Katni, I've been in contact with her, and I think the Ottawa Hospital as well, that they are trying to start these programs in addition to what they already have. It's resources. So, for example, we're very fortunate to have physiotherapy and psychology. Some programs might only have OT and physio. So it's whatever the resources that programs have to try to put together programming to best support the women in need.
Matt?
So what's the variability in symptom presentation for women with this if it's going misdiagnosed for so long?
So I think what makes it difficult is it's so varied. So pelvic pain to one individual may look completely different to pelvic pain for another. And that's why if I go back to one of my first few slides, I kind of said this is the umbrella term and there's all these underlying diagnoses that are often contributing to why somebody's pelvic floor starts to dysfunction. So that's part of, because of the multifactorial etiology, it makes assessment difficult, diagnosis and treatment difficult, and getting women into programs sooner more difficult. Does that answer your question? Kind of?
Not really.
Okay.
Any more of the actual symptom presentation?
The actual symptom presentation.
It's so broad.
Yeah.
Really take time to.
So what I can answer about that is the women that we've had in our program so far. So far, the typical woman that will be as part of our program is a 30-year-old woman, again, who's had pain and symptoms for about 10 years. The majority of them have endometriosis and have issues with sexual functioning, going to work, social functioning. In terms of their pain, is that particularly what you're looking for, their pain presentation? So a lot of them will report things like pain in their lower abdomen, issues with urinary and bowel functioning, issues with sexual functioning, that sort of thing. So those are the big ones.
So, veteran who was diagnosed with prostatitis concomitant for three surgical procedures to open his bladder outlet.
Yep.
He's continuing to have pain.
Yes.
He's stopped working.
Yeah.
And it has completely paralyzed him.
Mm-hmm.
So fortunately, he's been to a program.
Oh, yes.
Sometime in the next month.
Okay.
And I didn't go over around the program. And, but I think the word goes out. I think it's probably underreported in men.
Definitely.
And you have to look at how when it's time to get program men.
Yes.
Clearly more women.
And so,
And if anybody doing thinking
in terms of the men.
men,
Yeah. So thank you for the question. The question was briefly that you, Dr. Zacharias, had assessed a male today with chronic prostatitis who had surgery that's completely impaired his life and his functioning and how he lives. You're guessing that it's underreported in men, and what's kind of going on in our literature in the world in terms of treatment programs for males with chronic pelvic pain. And so I completely agree. I think that it's underdiagnosed in men for sure, and potentially even more underdiagnosed in men than women because of a variety of different socialization practices. And women are now starting to come forward with it, but men are less likely to engage in healthcare for those kinds of reasons. I think there are some programs in BC. To the best of my knowledge, I don't think they involve physio. I think they have physician-based and then the physician-based, and then psychosocial. I'm not sure what kinds of programs are happening in Toronto, but to the best of my knowledge, this kind of program does not currently exist for men in Canada. It's something that we're definitely interested in adapting our program and seeing how it does with males, and adapting some of the exercises and techniques, but essentially a lot of the classes and a lot of the key factors that impact men will be similar in terms of down-regulating their nervous system, in terms of learning to cope with emotions, and dealing with previous trauma, and again, with communication and sexual intimacy.
Yeah.
Do you see presentations of persistent pelvic pain that don't have significant pelvic floor musculature involvement?
So to date, what we see, and I can also let Adria talk more about this because she's the actual one feeling the pelvic floor. Sorry? Assessing the pelvic floor. To be more appropriate here. If anything, I would say that we have more women coming in saying they don't have any issues, it's not a problem, and then when the pelvic floor examination starts, you start to notice significant tension. So if anything, I would say it's the opposite. I would guess that a lot of women, and probably men too, have pelvic floor dysfunction that they're either not realizing is there or not realizing what it is, or it's radiating and contributing to other kinds of pain presentations that they're coming in with. So I think in the next couple of years and decades, this is going to be an area that we're going to learn more and more about for sure. Did you want to?
So what I noticed with the assessment is I would agree with what Dr. Kat said. There's sort of a lack of awareness of their pelvic floor. They know they have pain. A lot of it's talk about back, maybe down their legs, and through their groin. But the awareness of their pelvic floor, nobody talks about it. Physicians don't talk about it. They kind of try to skip over it. It's the first time someone's actually asked functional components of their pelvic floor. Like, are you having difficulty with sexual intimacy? Are you having difficulty urinating? And like, so we go through those with the red flags and we're looking at back problems. But to link it to our pelvic floor is relatively new. And I think it's the first time some of these women have even thought about it. I don't even think of my pelvic floor. There's no awareness of it. So that's one advantage of having a pelvic floor assessment. And what I would say for the majority of the women that we've assessed so far, there is an increased percentage of hyperkinesis, meaning that the pelvic floor muscles are tight and shortened. And not only that they're tight and shortened, but I would say there's a lack of knowledge or ability to know how to lengthen the floor. So when I talk about, like, okay, we all know how to tighten and contract our biceps, but to be able to lengthen our biceps, well, I have no idea how to do that. I don't even know what that is. So the one advantage we do during the assessment is we do a little bit of biofeedback. So we get them to understand how to tighten that pelvic floor, but more importantly, functionally lengthen that pelvic floor. So we do that both at the initial assessment, but also during the fitness classes, they're learning things they can do themselves. But again, really what you said was about being aware of that. And I would say that's totally the same with men.
Go ahead.
So I would like to go back to the demographics.
Mm-hmm.
We were talking about, I believe, if I remember well, 66% of the women out of the group of 9, 66% surgery. In this surgery, do you itemize what kind of surgeries they had according to their condition that they were like, for example, if I'm correct, endometriosis is only diagnosed with the So I would suggest then that, not suggest, but I would think that women with endometriosis have they had other kinds of surgery? If any of these cases they're having, has any of this pain originated after surgery? And was it there prior to surgery that it got worse? So I'm just a little bit sensitized.
Of course.
When we are focused on the institute here about post-surgical pain, and I'm just thinking that it would be a good idea. I probably you're already doing it, and I'm just, thinking out loud right now in terms of getting a little bit more data, perhaps, if you're already getting it, about the kinds of surgery, when they had, and what was their condition before and after.
Right.
I think that would kind of enrich the data set.
Mm-hmm.
Give us a lot more information.
Absolutely. So thank you for the question. The question was if we've looked at what kinds of surgeries they've had when on the slide about treatments tried, because particularly for endometriosis, a lot of the surgeries are lap surgeries, and how did their pain either begin or change post-surgery. So we, as part of the assessment, we do ask what kinds of surgeries they've had and what times. To the best of my knowledge of the women that we've assessed so far, none of them have not had pain before surgery. So even if they're having laparoscopy exploratory surgery, they're all having it because of pelvic pain. Majority of patients do have pain post-op, and that's again a sampling selection. We don't get to see the patients who are doing really well post-surgery. We're only seeing the patients who require support and are really struggling to cope with their pain and a variety of other conditions and reasons. So my dream, hopefully in the near future, would be to be able to run this program with just general people, our general pelvic pain patients that are coming in, about on average 10 years since experiencing pain with lots of surgeries, and then also have another group of women who are, let's say, 6 months post their first surgery to be able to determine post-surgery if this kind of program can help women from developing post-surgical pain. So that would be a dream of mine to be able to run that study, and hopefully as this program kicks off, we'll have the end to be able to construct something like that. Oh, I think that.
Can you put up that slide, Laura, with the outcomes?
Yes.
So which of those do you think are impressive outcomes? Like, have you identified, obviously it's a multifactorial problem.
Right.
And certain people respond to certain aspects of your program more than others, right?
Mm-hmm.
Have you been able to pick up on that?
Yes.
There's a pattern?
Yes, and I'm smiling, sorry.
Yeah. Because, with respect to the central sensitization, that figure looks pretty decent, but the rest of them look pretty close. I mean, for a small sample size,
Exactly.
I wouldn't get terribly excited about that.
Yes, so thank you for the question. The question was about our results and which we're excited about, and some of the other ones potentially don't have enough variability to, get excited about a significant outcome. So to start with kind of the smaller guys, on 8 people, it's really hard to run a parametric t-test because it's driven by n. So with a low n, it's virtually impossible to get anything significant. So one of the reasons I was excited is because the statistic was veering on significance, and with such a low n, this is exciting. So hopefully when we add more people to the pot, we're going to have more variability, so these numbers are going to look more and more different. But exactly, I mean, it's too soon to tell for sure. The number that we are really excited about, and which is why I'm smiling at Adria, is because this central sensitization, so it's something that we don't often see in the literature all that much, and there's a pretty big discrepancy between the mean before and the mean after, and you know, it's a full program and there's lots of components that contribute to this, but it's also a significant, you know, accomplishment for Adria and the physiotherapy component to be able to show that, you know, by learning to unwind your nervous system, both with physiotherapy and things like mindfulness and emotion regulation, we can see quite a significant drop just in the span of 8 weeks. So if I were to put my hat on something, this is the questionnaire that we're looking to investigate more on and see where that goes. Does that answer your question? Thank you.
Which I think also correlates with the reduction in stress.
Yes.
We're sort of going that direction.
Exactly.
Probably, even if you had a larger net, they wouldn't come out with statistics.
Exactly.
For now.
We'll have to see, of course. Yes.
So with central sensitization showing the largest potential change, that brings up to my mind the question of are you looking into any measures of autonomic dysregulation, like heart rate variability, flexibility, and
That's mine.
I know, because you need your mind here. Yes. Okay, so I will start with that, and I could also pass it off to you. So thank you for the question. The question was on the central sensitization that we're starting to look at measures of autonomic responses and sensitivity. So that is the dream. Adria has definitely thought a lot about heart rate variability, tracking devices, you name it. Our heads have been in the sky of where we can go with this. And my response is to unfortunately pull it a little bit down and say, I am not a psychophys researcher. So if there are any psychophys researchers that would like to collaborate with us, I mean, this is something that we're both very much interested in looking at the longitudinal data post-group. Some people? If anybody also has,
The fact is the heart rate variability one is probably actually technically very easy and cheap, because all you would need is a baseline ECG downloaded into, or a Holter downloaded into one of the analytic programs, and a follow-up.
Yeah, Dr. Zacharias and I spoke about trying to get funding to start that. It's just, again, putting that time aside to allocate to getting it started, finding the research behind it. But yes, Dr. Zacharias already said, okay, you tell me how much it would cost
and how it's going to go.
Your funding agent?
Well. So nice, thank you.
One of the things I was thinking, Laura, is that the pelvic floor physio and the counseling pieces and the psychoeducation are basically, they're not tied to a disorder. So you could come here, you could go and have a laparoscopy because you had pelvic pain. You could find out that you had endometriosis. You could start on the most appropriate therapy for endometriosis medically. But there would be no reason at all why you couldn't also be referred into a pelvic floor physio program, because it's not dependent on the disorder. And in fact, the rationale, as you say, might be simply if the pain had persisted, even though you're under optimal therapy for whatever condition it is, whether it's an inflammatory bowel disease or endometriosis, if your pain persists for X, then the first thing will be proceed into a pelvic floor physio and psychoeducational program. With the idea of achieving some kind of recovery, as you say, sooner rather than later. And a lot of times the 10-year delay is not because nobody knows what's going on. Well, that's not quite true. There are very well-known things that are going on, but the treatment of the pain part is not understood. And as you say, physio is not covered unless you get into a program like this, and psychoeducation is not covered.
Yeah.
So you can have all of the appropriate medical therapies, you can have perfectly appropriate surgery, and simply, in the absence of these two critical pieces of recovery, not not progress.
Absolutely.
And so that's an interesting, as you say, it sort of takes you to your ideal, which is early intervention. And, because I know Nick Leyland in OBGYN has been looking at the endometriosis therapy for a long time. And his review of cases is that probably in the last time I talked to him about this, 5 years ago now, he said, roughly 60% of endometriosis is not managed according to the current best practice guidelines. Mm-hmm. So, that would suggest, as you say, you need to be connected with the appropriate medical surgical services to make sure that the best care is administered. But none of this precludes going on with that.
No.
And this doesn't mean you've abandoned other treatments. It means it's like being told that you need to continue to exercise while you're waiting for your total knee. You still do. Doesn't make any difference.
No, and absolutely, I couldn't have said it better. And we've had a couple of patients that have come through, and they kind of ask, I have this surgery scheduled for 6 months from now. Should I wait until after I do the surgery? What do I do? And our comment is always, before or after surgery, 10 years from now, 10 years before, this program is only going to help you. It's only going to help you learn to cope. It's only going to help you learn to relax your muscles, downregulate your nervous system. And it's probably going to help you cope with the pain post-operatively anyways. So we always suggest patients, like you said, to come into the program, learn those skills and strategies, and they're going to have better outcomes afterwards.
The other part is that with respect to the men's program, I think you're correct that there's nobody doing an interdisciplinary program, but there is I saw Curtis Nichols' name up on your collaborator set. So he's at Queens. Mm-hmm. He has a colleague at Mount Sinai whose name escapes me right now, which is dumb because I did like an hour and a half long phone call with him. I expunged from my memory. But he's a urologist whose specific area of interest is pelvic pain in men. Mm-hmm. And so they've developed a consortium of, it sounds like about five urology focusing on men's care, investigators across the country looking at, so that would be a good link, to try to drive something like this.
Absolutely. And so most of my graduate training was from Queens, and my patients are from Dr. Nichols' office. So I sat through, I think, 217 of his clinic visits to hear all their patients and their stories. And in my training at Queens, there was a nurse, there was a male and a female nurse, and then Dr. Nichols. So there was no psychosocial piece at all, and it would be exciting to hear that some psychosocial piece would be added to the Toronto program if they have a group going together.
So those are connections.
Sure, thank you. Yes?
If the downregulation of the nervous system is so important, does that mean that really neurology at this point is actually psychological?
That's a good question. So the question was, if the downregulation is a key component of these kinds of conditions, is it in fact psychological? And I would have to say no and yes and no. And with that, have a good evening. And as you can imagine, for many of these chronic pain conditions that we don't really have a strong etiology base, psychology definitely affects it because it can regulate your nervous system, but it's not necessarily the cause of it. So I love the psychoneuroimmunology, all of that literature, especially in some of the stuff where they'll stress rat pups out and then look at their equivalent of 10 years later, and you start to see them developing all these chronic conditions. So I don't necessarily think the rat pups are sitting there and behaviorally disactivating themselves and feeling bad about their life rules, but there's something about their experience that starts to impact their nervous system and their immune functioning.
And with that, I seriously am going to finish now. Just after 6:30. Laura, thanks very much. It was a great talk. Congratulations, Laura, on creating the program. And, well done.
Thanks for having me.
Thanks, everybody.